So that's the part one of this talk. And the part one is basically this. In 1980, the American Psychiatric Association, for guild reasons, decided to rebrand itself. They wanted to rebrand themselves as doctors in white coats who treated real illnesses of the brain. We then heard, the public was told, that they discovered that chemical imbalances were the cause of major disorders, that new drugs fixed those chemical imbalances like insulin for diabetes, all which is a story of great progress. And this led to a great expansion of the psychiatric enterprise. In 1987, we were spending United States, about $800 million in psychiatric drugs. In 2007, we were spending $40 billion in psychiatric drugs in the United States, a 50-fold increase in market size. And as that story was told, we weren't told about what research was telling us about the chemical imbalance story, that it hadn't panned out. We weren't told about how the drugs abnormalized brain function, and we weren't told about poor long-term outcomes in NIMH-funded studies. So we have this extraordinary gap between what we're told and what the research shows. Now, real quickly, and I'm running a little bit behind, so I'm going to go quickly through this if I can. I just want to show that there's a history of science regarding the long-term effects of antipsychotics and of antidepressants. And I'm going to focus mostly on antipsychotics, and here's why. The conventional wisdom in the conventional story goes like this. Antipsychotics arrived in asylum medicine in 1955, and this kicked off a psychopharmacological revolution, a great advance in care. And of course, we now are told that people with schizophrenia and psychotic episodes have to be on antipsychotics, that when they come off, they relapse all the time. And this is seen and that it was the antipsychotics that made people to live fairly normal lives in the community. We've heard that at various times. So this whole psychopharmacology revolution, at the heart of it is a story of how drugs were introduced that helped tame psychosis, that helped dramatically improve the long-term course of psychosis. So what I want to do is see does the data support that story? And what we're going to do is we're going to look at some studies that were done in the 1960s and 1970s on the first generation antipsychotics. And then we're going to look at the second generation. The second generation are like Risperdal, Zyprexa, Seroquel, et cetera. And we're going to see if all this research comes together like pieces of a puzzle to tell a story about the long-term effects of antipsychotics. So one of the first studies that was done at Boston Psychopathic Hospital. They had 5-year outcome data on a 1947 cohort of first episode psychotic patients and that were discharged. And then the relapse rates within 5 years of discharge was 55%. They had a similar group of first episode patients treated in 1967 with drugs, and their relapse rate was higher in the 5 years after their hospitalization. And here's the big difference. In the 1947 cohort, 76% were successfully living in the community at the end of 5 years, meaning they weren't on disability. 67 cohort were much more socially dependent on welfare and needing other support than the 1947 cohort. So what do they say? The researchers. Rather unexpectedly, these data suggest that psychotropic drugs may not be indispensable. Their extended use in aftercare may prolong the social dependency of many discharged patients. There were other studies of this in the 60s that raised questions about the use of antipsychotics. So in the 1970s, the NIMH funded 3 studies to look at the longer-term impact of antipsychotics. The first was done by Maurice Rappaport, a hospital in California. It was randomized. You had, I'm pretty sure this was first episode patients. They come into the hospital. They're either randomized to placebo in the hospital or to antipsychotic in the hospital. Then they're discharged and they're followed for 3 years. And during this 3-year period, they're free to either go off their medications or start taking medication. So what you have here is there were 41 people randomized to placebo in the trial. Placebo off means 24 were treated with placebo in the hospital and they remained off during the 3 years. Placebo on means they were treated with placebo in the hospital and then went on antipsychotics in the 3 years. Antipsychotics off means treated with antipsychotics in the in the hospital, and then they went off. Now look at the outcomes. The best group by far is the group that were never exposed to antipsychotic. Their severity of illness was the least at the end of 3 years, and the rehospitalization rate was 8%. What this is showing is that about 2/3 of first episode patients, if not put on antipsychotics, can recover over time and do fairly well and not go down a chronic course. And you'll see you can go on antipsychotic off, much worse, but the worse is, in fact, antipsychotic and then continual use. And they had this is the recommended form of care. They had the greatest severity of illness and the greatest rehospitalization rates. So what did Rappaport suggest? And you can just read this real quickly. Just read it yourself. His conclusion is basically we need to rethink this if we're looking at long-term clinical improvement and functioning. As you'll see, the unmedicated while in hospital group showed greater long-term improvement, less pathology, fewer hospitalizations, etc. Now, the next was a famous study done by Loren Mosher called the Soteria Project. And in this project, newly diagnosed patients were randomized either to treatment as usual in the hospital or to a residential home, Soteria staffed by ordinary people. The home actually was, this experiment ran for 10 years. It was directed by, the director was Voice Hendricks, the cousin of Jimi Hendrix. And those randomized to Soteria were not immediately put on antipsychotics, and initiation of antipsychotics would begin only if patients failed to improve or deteriorated. As I said, it ran 12 years. Here were the results. At the end of 6 weeks, the group that was treated initially in Soteria, where antipsychotics weren't immediately used, they had the same improvement in psychopathology at the end of 6 weeks of those treated regularly with drugs in the hospital. At the end of 2 years, this form of care, which really made use of selective use of antipsychotics, had better outcomes, lower psychopathology scores, fewer readmissions, better global adjustment. And here's the kicker. In terms of antipsychotic use, 42% never been exposed to the drugs, 39% used them temporarily, and 19% used them regularly. So what you see from this is better outcomes with the selective use of the drugs. And again, they said minimal use actually seems to be advantageous. Loren Mosher, by the way, was the head of schizophrenia studies at the NIMH when he conducted this study. We think the balance of risks and benefits associated with the common practice of medicating nearly all early episodes of psychosis should be re-examined. Second study. The third study was done at the NIMH's own in-house facility. It compared 27 schizophrenia patients treated with psychotherapy and no antipsychotics to 22 patients treated with both psychotherapy and antipsychotics. You see those treated without drugs were discharged sooner. They had a lower relapse rate, and most important, they suffered less from depression, blunted emotions, and retarded movements. So all three studies done in the 1970s raised questions about the long-term impact of antipsychotics, including whether they were making them more chronic. And here's what William Carpenter wrote in 1977. He says, there's no question that once patients are placed on medication, they are less vulnerable to relapse if maintained on the drugs. And that's the information from studies where you take people who've responded well to antipsychotics. One group is randomized and taken off the drug. The other group is by randomization, is continued on the drug. And those taken off the drugs usually abruptly have higher relapse rates. But watch this question. What if these patients had never been treated with drugs to begin with? We raise the possibility that that antipsychotic medication may make some schizophrenic patients more vulnerable to future relapse than would be the case in the normal course of the illness. Thus, as with tardive dyskinesia, we may have a situation where neuroleptics increase the risk for subsequent illness, but must be maintained to prevent this risk from becoming manifest. So they're saying here, in the 1970s, maybe these drugs are making people more biologically vulnerable to psychosis and therefore have a worse long-term outcome. Then two researchers from McGill University put together an explanation for what was happening. They said, once again, there's normal functioning. The drugs block the receptor. The brains increase the receptors. And then they said, once this happens, there's a dopamine supersensitivity that has been induced in the brain. Okay. Once there's this adaptation to the drug, and they said, Neuroleptics can produce a dopamine supersensitivity that leads to both dyskinetic and psychotic symptoms. The drugs are causing a change that increases the risk of psychosis. An implication is that the tendency towards psychotic relapse in a patient who has developed such a supersensitivity is determined by more than just the normal course of the illness. So that's where we were at the end of the 1970s and beginning of 1980s. There was research showing that over the long term, it seemed that antipsychotics were increasing the risk of relapse and impairing functional recovery. And there was a biological explanation for why antipsychotics had this effect, okay? Now, in 1980, we get DSM-3. Later in the 1990s, we get the second generation of antipsychotics. And what we want to see now is research that's been done since then, does it agree with that worry that arose in the 1960s and 70s? In other words, does it provide supporting evidence, or does it contradict it and say we don't have to worry about this drug-induced dopamine supersensitivity? And what you find, well, now we'll just real quickly go through every type of research I could find. First, there were cross-cultural studies done by the World Health Organization in the 1970s and 1980s. One was 2 years in length, one was 5 years in length. And what they did is they compared outcomes in 3 developing countries, India, Nigeria, and Colombia, with outcomes in the US and 6 other developed countries. Everybody was diagnosed by Western doctors, so there was a standardization of diagnosis. And what did they report each time? That those people diagnosed with schizophrenia in the developing countries had a considerably better course and outcome than in the US and 6 other developed countries. They even wrote that being in a developed country was a strong predictor of not attaining a complete remission. And in the poor countries, they had exceptionally good outcomes. Now, after the first such finding, the World Health Organization investigators hypothesized maybe the reason for the better outcomes in the developing countries is the patients are more medication compliant. They don't stop taking the drugs like many people do in the developed countries. So they looked at medication usage in the second study, and here's what they found. Only 16% of patients in the developing countries were regularly maintained on antipsychotics, means that drugs were used acutely but not chronically, where, of course, maintenance therapy is the standard of care in the rich countries. So we're seeing better outcomes where the drugs are only used short periods of time for most people, not long-term. And then when they went back 15 to 20 years later, they found that there was a significant outcome differential between patients in the developing countries versus those in the rich countries. And look in the developing countries where drugs weren't used, antipsychotics weren't used on a continual basis, 53% were never psychotic anymore and 73% were employed. So at least in this cross-cultural study, it supports this worry that antipsychotics are worsening long-term outcomes. Now, this is Martin Harrow's long-term study of psychotic patients. I gave you the one graphic from that study earlier. He enrolls 200 patients. He's a psychologist from Illinois. The study was done also with a psychiatrist named Thomas Job. They enrolled 200 patients that came to either one of 2 hospitals, a private hospital in Chicago area or a public. And at 15 years, they still had 145 patients in their study. Here's how the study, and you'll see it's the cohort. They get admitted into a hospital. They get treated with antipsychotics, and you'll see 64 of the 145 were diagnosed with schizophrenia, 81 with milder psychotic disorders. And here's what's important: it's a young group, so we're going to follow them. We're going to follow them from an early point in the course of their disorder. This is the first hospitalization. And the way the study works is this: they're all treated with antipsychotics in the hospital. Then they're discharged. And now they're free to do what people do after they're discharged. They can either continue taking their medications or they can go off. And what Martin Harrow and Thomas Job are going to do, they're going to follow up at 2 years, 4.5 years, 7.5 years, 10 and 15, and eventually 20. And just look at how well are they doing. Are they taking antipsychotics? Are they psychotic? How anxious are they? Are they working? That sort of thing. So here's what you see at the end of 2 years. At the end of 2 years, roughly 25 of the 64 schizophrenia patients were off the antipsychotics. Look what happens with anxiety. Those on antipsychotics remain very anxious, whereas it diminishes those who, as they get off and they recover from their psychosis. So much less anxious for those that got off, better cognitive function for those who got off. This is really key. Now, at one point, what they do is they compare those who never used any antipsychotic during the follow-up starting in year 2 to those who were medication compliant for up through 20 years. And what do you see? You see that those who stopped using antipsychotics at the second year and were able to get better and get stable remained very stable. They had low relapse rates. You see this in the bottom one. But look what happens to the medication compliant people who theoretically medication is being used to stop the psychotic symptoms. But in fact, about 2/3 at every follow-up or even higher would still have psychotic activity. Work history, much, much better for those off antipsychotics. And look at this, nearly 90% by years 5 were working, those were off antipsychotics. And by the way, those off antipsychotics had dropped out of the psychiatric system. Several had gone back to school. One became a lawyer, one became a teacher. And what Harrow and Job discovered, of course, is those that recovered in this way, they didn't tell people that they once had a diagnosis of schizophrenia and once had been in a mental hospital. And so what Harrow and Job says, we lose track of these people. We don't see these people. The only people that the psychiatrists see are those who go off their drugs and do poorly. This is the recovery rate, 8 times higher for those off medication. You'll also notice he divided his outcomes into recovered, fair, and uniformly poor. On the group that used antipsychotics for 15 years, 5% recovery rate, 40%, 6% fair, 49% uniformly poor. But you'll see only 16% uniformly poor for those off antipsychotics. So it's like the spectrum of outcomes had shifted. Here's what he concluded. Martin Harrow, 2008, I conclude that patients with schizophrenia not on antipsychotic medication for a long period of time have significantly better global function than those on antipsychotics. Now, I wrote about this in the book Anatomy of an Epidemic. Mad in America has made a big deal of it, but I guarantee you this conclusion, this research, it's just never been reported by the mainstream media. It's not in the textbooks, and it doesn't inform protocols. And the reason is because it goes against the conventional wisdom and conventional practices. Real quickly, you see in the milder group, it was the off antipsychotic group that did better. And now here's a really interesting thing. This shows you have 4 groups: schizophrenia on antipsychotics, milder disorders on antipsychotics, schizophrenia off, mild disorders off. Now, you would think that schizophrenia off would have a worse outcome than milder disorders on antipsychotics because they had a better baseline prognosis. But here's what do you see? The worst is schizophrenia on antipsychotics. Next worst is milder disorders on antipsychotics. Then it's schizophrenia off, milder disorders off. So how do you explain that milder disorders on antipsychotics has a worse outcome than schizophrenia off antipsychotics? The only explanation I can come up with is that the antipsychotics are worsening long-term outcomes. And again, this is just showing the difference. Those who stayed on antipsychotics, more psychotic, more anxious, worse cognitive function, lower recovery rates, much more likely to have a uniformly outcome, had worse global outcomes. He then raises the question, is very long treatment with antipsychotic medications undesirable? I think I'm going to skip the rest so I can get through this. There was a randomized study by Lex Wunderich in the Netherlands, and basically what he found was this. Those who were randomized to a drug reduction discontinuation arm, this is first episode patients, had a more than twice a recovery rate than those maintained on the drugs. And so he concluded the same thing. We needed to rethink this. There was a first episode study in Australia, and they had medication usage for 209 patients at the end of 75 years. You'll see the full functional recovery, 56% off that weren't using the drugs, only 14% that were. You see the same thing in a UK study, recovered at 10 years. It's those off who have a much higher recovery rates. Denmark did a 10-year study of 496 first episode patients. At time of recruitment, patients have been on antipsychotics less than 12 weeks. At 10 years, there were 303 patients still in the study. There were 120 who were non-compliant and had stopped taking antipsychotics. And there was no difference at baseline between those who were non-compliant and had stopped taking antipsychotics and those who were compliant and were taking the antipsychotics. And here's the difference. In remission, much more likely those off antipsychotics, and much more likely to be employed those off antipsychotics. So what you see from all these different studies over and over again, there are higher recovery rates, there's higher functioning over the long term for the group that can get off antipsychotics. Then we had MRI technology that came into effect in the 1990s, excuse me. Nancy Andreasen hypothesized that maybe schizophrenia is a progressive neurodevelopmental disorder characterized by progressive reduction in frontal white matter volume. She did a study of 500 first episode patients, and that's what she found. There was a progressive reduction in the frontal white matter volume. Then she and her colleagues reported that as this brain shrinkage happens, it's associated with a worsening of negative symptoms, increased functional impairment, and after 5 years, cognitive decline. She is at this point, remember, she's the editor-in-chief of Psychiatric Times, American Journal of Psychiatry. She is saying this is a disease process, and unfortunately, the drugs don't stop this brain shrinkage, okay? And this is why you get these poor long-term outcomes. However, a study in macaque monkeys found that, in fact, the drugs shrunk their brains, okay? And it was dose related. So all this, and these macaque monkeys obviously didn't have the disease of schizophrenia. So this raised the point that maybe it's the drug causing the shrinkage. So Andreasen goes back to her own research, and she finds that, in fact, the shrinkage is drug related. Use of the old drugs, the atypical drugs, and clozapine were all associated with smaller brain tissue volumes, with decreases in both white and gray matter. The severity of illness and substance abuse had minimal or no effect on brain volumes. In other words, it's not a disease process, this brain shrinkage. It's a drug-induced problem. And you'll see a review of 43 brain imaging studies confirms that antipsychotics shrink the brain. So think about what we have in this data. We have a story done by the leading editor of the American, we have research done by the editor of the American Journal of Psychiatry that says people treated with antipsychotics over time, because this causes a shrinkage of the brain. And as that happens, you see worsening of outcomes, negative symptoms, increased functional impairment, and after 5 years, cognitive decline. That is a story, a neat sort of summing up of an iatrogenic process of how antipsychotics worsen long-term outcomes. You have an agent that causes a known change, and that known change is associated with is then associated over time with worse outcomes. And guess what's happened since 1996? Recovery rates, in fact, have worsened in the antipsychotic era. They're now worse than they were before 1941. And just so you know that this isn't just me presenting data, as this data has become known, you are getting some people saying, we got to rethink the use of these drugs. And this is the editor of the British Journal of Psychiatry. You can read it. And he concludes, we have to reappraise the assumption that they should be a first line of treatment. There is an increasing body of evidence that the adverse effects of antipsychotic treatment are, to put it simply, not worth the candle. Now, I'm going to skip this part, but you'll see that there's the same story with the use of antidepressants. You'll see that it used to be seen as an episodic disorder. Most people, you could expect the depression to lift, especially at the end of 1 year. You'll see even in 1969, they said insurance can be given to a patient and his family that subsequent episodes of illness after a first mania or first depression will not tend towards a more chronic course. Then, though, you begin to see clinicians saying once they're using antidepressants, boy, it seems like my patients are maybe they're getting better faster, but they're relapsing more frequently. You're seeing one psychiatrist says they're inducing a change to a more chronic course. This Dutch psychiatrist tests it, and he does find that the use of antidepressants is associated with an increase in episodes and shorter time between episodes of depression. Now, in 1985, the NIMH convenes a panel, and the panel says, oh, we used to think it was episodic, but now we're seeing that it runs a chronic course. But they're not saying the chronic course is caused by the antidepressants. They're just saying, oh, we have discovered the true course of depression. But what they're really discovering is the course of depression treated with antidepressants. Then we had a couple studies of remission rates in real-world patients treated with antidepressants. This is a STAR-D trial. Look at this. Only about 35% ever admitted, even for a short time, but very low stay-well rates. And then at the same time, so these are the outcomes for treated depressed patients. They conducted a small study of what is the 1-year recovery rate of unmedicated depression, and you'll see that it was 85%. So here we have a documented stay-well rate of 3% with drugs, 85% without. And this is a study by Minnesota over a 4-year period. How many of their patients with a diagnosis of depression, and these are outpatients, are getting better each year. And you'll see that the number of patients that go into remission is very low. That's the blue, very low response rates, and most are remaining chronically ill.